Back again to the pathogenesis, so the main player is the uremia and the inflammatory aging, but we have a lot of contributors to frailty in CKD patients. We have the cognitive impairment and depression. We have the sarcopenia and the obesity, especially the brown adiposity, which is a pro-inflammatory source, as well as it leads to myosteatosis with more and more sarcopenia. We have the CKD MBD with a bone fragility and muscle incoordination and vascular calcification and cardiovascular bad outcome. We have the anemia and the polypharmacy. And when the patient is starting dialysis, we have the dialysis loss of nutrient and antioxidant. We have the intradialytic hypotension and endotoxemia that all contribute to frailty. How to assess frailty in CKD patients? We have two conceptual models. The first is, and the most validated, is a physical frailty model, which assesses 5 parameters: the weight loss, the walking speed, the exhaustion, the low muscle strength, and low physical activity. And this is best measured by the frailty phenotype. But the most holistic is the frailty index, which measures the cumulative deficits frailty, not only the physical one, but also the functional and the cognitive decline, as well as the undernutrition and the disability. So these are the measures for frailty assessment in CKD patients. As we mentioned, the frailty phenotype, which is the most validated, and it is highly correlated with the increased mortality risk and rehospitalization, but it has a disadvantages of being only measuring physical domains, and physical tests are needed, and the weight loss somewhat is not practical in hemodialysis patients. The frailty index is the most holistic. It measures 70 variables consisting of a variety of medical and psychological as well as functional impairment, and it is highly validated in CKD patients, but it is time consuming to calculate. The short physical performance battery depends on 3 physical assessment measures, which is a standing gait, the gait speed, as well as a chair stand test, but each parameter gives a score from 0 to 12 so as to increase the range to assess the mild cases. It is validated in CKD patients, but also it is only dependent on the physical domains. The Kroken-Jan frailty indicator is depending on 15 questions across 8 domains, covering the physical, cognitive, psychological, and psychosocial elements. It is predictive of death and rehospitalization, but being subjective, it is less sensitive. The multidimensional prognostic index include 8 individual assessments, including function, polypharmacy, mental state, and others, and it is associated with hospital mortality in CKD patients only for admitted CKD. It is not validated for outpatient CKD. And the most common for screening is a clinical frailty scale, which is a 6-point scale, which is associated with increased risk of death and hospitalization, but being subjective, it has no robust validation in CKD, but it is simple to be put in your clinic so as to screen your patient whether he is screen or is frail or not. To manage frailty in CKD, it needs a multidisciplinary team so as to support the physical, psychosocial, cognitive, as well as the environmental issues. And these are the tools, starting with the nutrition. It should be personalized, and KDUKI put a lot of recommendation for protein restriction to various CKD stages, as well as advocate also nutritional supplementation for protein energy wasting cases, whether orally or enterally or even parenterally. The physical rehabilitation is a very important issue to apply for managing your frail patients, and the KDIGO recommend moderate intensity physical activity for at least 150 minutes per week, or to a level compatible with their cardiovascular physical tolerance. The effect of exercise in hemodialysis patients is heavily studied, and this Cochrane review showed the benefit of exercise in the physical components of the quality of life, as well as the mental component and the depression as well. Also, it has a positive impact on the functional capacity as measured by the 6-minute walking and the sit-to-stand test. Which modality to prescribe, whether intradialytic or home-based, this is a controversy. The intradialytic was shown in the diet trials, and they give a very good results in improving the physical functioning as measured by the sit-to-stand test. Also, the quality of life was improved, and the hospitalization was less. And the home-based exercise was advocated in this meta-analysis, which showed the positive impact on the home-based exercise, not only on the physical components, but also on the cardiopulmonary fitness, as well as the quality of life, and this was the results. Much more important is the long-term effect of the home-based exercise that shown that after 3 years of follow-up, there is around 30% reduction in the mortality, as well as around 45% reduction in the hospitalization. And this is one of the very important advantages for the home-based exercise, that it can foster a habit of regular physical activity. Besides being cost-effective and flexible, but among the disadvantages of this modality is the poor adherence and the safety issues. While the intradialytic the intradialytic exercise has the advantages of being supervised with high adherence, with improved dialysis efficiency, but it is costly. For rehabilitation to our patients pre-transplant, this study showed that it decreased the prevalence of frail as well as a severe form of frailty if you conduct exercise for your patients 2 months before the surgery. And after renal transplantation, there is this meta-analysis which comprised 17 randomized controlled trial and show a positive effect on physical fitness, physical functioning, quality of life, and bone health as well. The polypharmacy and the deep prescription is an issue because polypharmacy increases the risk of fall and fracture and frailty. And if you discontinue medication that deemed to be unnecessary, this will improve the patient functional mental state and reduce the risk of fall. The renal replacement modality which you are going to choose, the best is the transplantation, as the frailty improve 3 months after transplantation, and the PD is preferred than the hemodialysis for frail patients, and moreover the home-based dialysis should be considered for frail patient if it is available. And if the patient is on hospital hemodialysis, so it should be personalized, and the elderly frail patients may need only twice weekly sessions of shorter duration, not the usual hemodialysis prescription. The social and family support are very important as they improve the physical activities, reduce disability, and improve treatment adherence. Are there any adjuvant supplements? There are very few studies in these issues, and these are the lists, starting with the senolytics. The dasatinib was used in a very primitive study, and it was found that it decreased the senescent cells. Those senescent cells with senescence biomarker, the P16 positive and P21 positive adipose cells, and there is a concomitant decrease in the cytokines, but the clinical effect was not proved. The oral nutritional supplements was give a good results for our frail patients, and this was showed by the improvement in the 6-minute walking test and muscle strength, but the effect is more profound when they are added to the exercise. The anabolics give a good increase in the body mass index, but because of their side effects, they are of limited value. The antioxidants improve the body mass index and increase the muscle and bone mass. What is much important is steroid reduction and withdrawal that was associated with improvement in the cardio-respiratory fitness, as well as measured by the peak oxygen uptake, and the muscle strength as measured by the quadriceps peak tongue. So in conclusion, ladies and gentlemen, frailty is prevalent among CKD patients and have a poor adverse outcome. It should be assessed and different measures are present. Frailty phenotype is the most validated and the frailty index is the most holistic. So, and the management should be depending on a multidisciplinary team so as to give physical, socio-cognitive, psychosocial, and nutritional support. And thank you.